My differential diagnoses, my three differential diagnoses, three, we've got a little bit of the sickness today, is peptic ulcer disease with a perforation, a ruptured aortic aneurysm, or an MI. So we're going to start with the most likely of those, which is the peptic duodenal ulcer with a perforation. Now, I actually can't prove that this is not what is happening in this patient. He does have a history that indicates it is possible. He takes omeprazole, which is a proton pump inhibitor, which is often prescribed for people with gastric ulcers. So we're going to explore his history there a bit and find out why he was put on it in the first place. The gradual onset is not or fits this diagnosis, as well as the possibility of it perforating. Today, nausea, vomiting could also be symptomatic of exactly this problem, as well as becoming increasingly painful 1 to 2 hours after eating, as that's when gastric emptying would be happening, and there would be gastric contents being spilled into his duodenum, which if he had a large bleeding ulcer or even a perforated one, is going to cause a lot of irritation, inflammation, and pain. The anorexia also kind of, that is the anorexia. So that kind of works. Sometimes if you have a really severe gastric ulcer, even in that region, you can have vomiting of blood, but usually that would be if frank blood especially would be if it's in your actual stomach. Now we're talking about below your pyloric sphincter, so that technically is supposed to keep stuff from going up. So we're looking at it probably going down. He hasn't had many bowel movements. He states he hasn't had any that he has seen blood in or were dark, black, tar-like, coffee ground-like. He hasn't had many bowel movements recently. The last one was 3 days ago, but he also has not been eating or drinking. However, if there was blood in his digestive tract, that likely would continue to be passed down and perhaps would be noticeable. However, sometimes it just isn't. These gastric bleeds like to be really sneaky. He isn't distended in his abdomen, at least not visibly. He's not complaining of a sensation of distension, which also can show up when there is some sort of GI bleeding going on. The Cullen sign around his umbilicus would support this as him having a perforation in his peritoneum that is bleeding. He doesn't have a fever, but once again, we are looking at somebody who just took Tylenol before we arrived, about 1,000 milligrams, could be hiding a fever. He does seem to be in a significant amount of pain. His systolic blood pressure is not very high, but his diastolic is around 100. So it's quite possible that he is compensating and also in a lot of pain. His heart rate is 79. So either it's getting tired or it's possible he was an athlete in another life. I don't know. We can explore that a little bit. For a triple A, the Cullen sign could be possible because it could be bleeding within the peritoneum. Part of the descending aorta is in the peritoneum, but he doesn't describe it as a sudden onset. Frequently they're sudden onsets, not always. They can be a dissection that is slow. And he also describes the sensation as burning and not stabbing or tearing, which are often associated with triple A. We do not have bilateral pressures on him, but that is not always relevant depending on where the aneurysm is, if it's in his aortic arch or if it's in his descending aorta. He doesn't report any numbness or tingling in any of his feet or hands. He doesn't have unilateral weakness. His ECG is also normal, and there can be changes on that from a dissection or a aortic aneurysm. He's not complaining of the need to have a bowel movement. Now, we always suspect with nausea, vomiting, and epigastric pain an MI. His ECG is relatively normal. It's pretty much completely normal, so that's excellent. He doesn't have a cardiac history, and the symptomology that he is showing of Cullen sign, along with the increase of pain after eating and drinking, do point to something more likely GI related. However, with Cullen sign, this is a sign of a bleeding emergency, so he needs to go quite quickly to the hospital either way. He doesn't have any pedal edema as well. The two other possible differentials that were easy to rule out when we arrived were ectopic pregnancy. That one's highly unlikely, I'm going to say. And he denies any abdominal trauma, which is also a common cause of peritoneal bleeding. Thanks.